Okay, we can end the poll. Again, a mixed response. 38% of them have told that it's human position, but the right answer is actually Lawrence position. So this is actually 90 degrees of abduction and 90 degrees of flexion. It's extreme flexion and abduction. This is Lawrence position. Some of them have told it as Lange position. Lange position is actually in complete internal rotation. That will be in complete internal rotation, also called Lawrence 2 position. So let's move to the next slide, which is I'm waiting for Sukayan to launch the poll.
Yes.
Which of the following is not suggestive of hip dysplasia? These are radiological indices. A is acetabular index more than 30 degrees. Lateral central edge angle less than 25%. Posterior wall sign is C. And D is anterior central edge angle less than 20 degrees. It's very interesting. We have about only 17, 18 people, but still we have get responses for all choices. There is no response for 0%.
Yes. So the questions are really pertinent then.
Yeah, and these are common questions which they need to know at this. No.
Can I end the polls?
Yeah, we can.
Oh, it's still increasing. Okay, let's wait. Okay.
Sure. Yeah, so 46% of them have told posterior wall sign, and that's a right answer actually. So rest all are indicators of dysplasia. Posterior wall sign actually is a radiological sign which says that there is posterior over coverage. So it's not dysplasia. So let's go to the last and the final question. Can you?
Yes.
Which of the following pelvic osteotomy does not alter the shape of the pelvic outlet? A is Steele's osteotomy, B is Bernese triple osteotomy, C is interlocking PAO, and D is Bernese PAO. How? All this while I was thinking that we had at least 2 0%. Suddenly it changed. Guys, it's interesting. Right, you can end the poll, Sukayan.
Okay.
So 50% of them have told Bernese PAO as the answer, and that is the right answer. Rest all are variants of triple non-mate osteotomies, where the posterior column also is cut. In Bernese PAO, the posterior column is left intact, so the pelvic outlet is not changed, and particularly in girls, they can have normal delivery after a Bernese PAO. So that comes with that, we come to the end of the poll, end of the pre-test. Can you stop the poll? Sukayan?
Yes, I have already. Or it's still going on.
Yeah, yes. Poll is coming in the screen. Yeah, good. I'm just, yeah, Hitesh is here. Sandeep is there. Hi, Sandeep.
Hi, Venkat.
Oh, finally you made it. I was just thinking.
Yeah, no. Can you see me?
Yeah, we can see the Indian flag.
Hello.
Yeah, Sandeep, we can see the Indian flag in the background.
Hello, Venkat. Hello, Sandeep.
Hi,
No,
Hitesh.
no, I am
Hello,
I'm
Sukayan.
called Divya.
Hello.
There is very poor range, but I'm here.
Okay. Thank you.
Is
Thank you for.
Sukalyan here?
Yes,
Yeah,
yes,
Sukalyan
yes.
is there.
Yes. So glad you made it.
Hi,
Thank
Sukalyan.
you, sir.
So good evening, sir. Dhiren sir is here.
Good evening, Dhiren, sir.
Yeah.
So we just now finished the pre-test. And I think it's time that we can start the session. Good evening to all of you and welcome to the 6th lecture series in the POSI Gurukul session. And today's topic is on developmental dysplasia of the hip. And today's guru is Dr. Sukayan, who is an assistant professor of orthopedics in Guwahati Medical College in Assam. And he's a very young and dynamic pediatric orthopedic surgeon. He had his pediatric orthopedic training in Mumbai, and as well as he did a short stint of fellowship in the UK as well. And now he's practicing in Guwahati. Welcome, Sukalyan, and thank you for accepting to be a guru for today's session. And we have
It's an honor for
two
me, sir.
dynamic personalities as Sadgurus today. Dr. Thomas Polokaran, who is a professor and head of pediatric orthopedics at CMC Vellore. And Dr. Sandeep Patwardhan, again, professor of orthopedics and the pediatric unit at Sancheti Hospital in Pune. Welcome to both of you, and thank you so much for accepting to be Sadgurus for today's session. And with this, I think we can start the session. Sukalan, I'll stop sharing the screen. You can start your lecture.
Okay, sir. Good evening, all the participants who have joined from all across India and also overseas. Today we are going to discuss on the developmental dysplasia of hip. I thank the POSI, especially Dr. Dhiren Kanjwala sir, and also Venkatadas, who has initiated this noble endeavor and is taking it forward with great success. Dr. Sandeep Patwardhan and Dr. Thomas Palokaran both have been teaching me so many things over those years, and they have rightly taken the position of Sadgurus. So let us start the 6th lecture of POSI PG Gurukul. Now, the idea behind POSI PG Gurukul is to take extensive topics and make them concise, understandable, amenable to practical life, and also it is made a bit exam oriented. So today's topic is such an extensive topic, which is called developmental dysplasia of hip. Our learning objectives would be to have an overview of the spectrum of hip dysplasia. We have to also get acquainted with the relevant clinical and radiological features, management, and outcome. And since this is an examination oriented course as well, so we would like to keep the reference of Taxian's pediatric orthopedics as far as possible so that it can be quoted easily during the examinations. So the very name congenital dislocation of the hip is gradually getting phased out, even though some of the doctors still like to call it this way. This is because of our increasing understanding of the developmental dysplasia of the hip, which we know it as the spectrum of disorders rather than a single entity of dislocation. And this disorder pertained itself to the development of the hip, that the disorder which presents in different forms at different ages and at different stages. So as American Academy of Pediatrics rightly described is as a condition in which the femoral head has an abnormal relationship to the acetabulum, and rightfully this can be quoted everywhere. So what does this spectrum consist of? Easy to perceive that it consists of dislocated hip. Also, it consists of subluxated hip, those hips which are dislocatable due to abnormal hip joint development, and some of those hips are normal at birth, but ultrasonography or other investigation modalities pick it up sufficiently early and predict that these hips are not going to do that well in their future. So the whole thing is included in the spectra. It has been near about 200 years since DDH has been first described. Over then, unfortunately, the initial emphasis was on quick reduction, forceful reduction, and immobilization in the hip spica, and because of which some of the hips could not tolerate the forceful reduction and went into avascular necrosis. Gradually, fortunately, we have been trying to emphasize the early diagnosis rather and useful clinical tests, and the real revolution came when Arnold Pavlik emphasized his Pavlik harness, which is a non-rigid mode of immobilization for the reduction of DDH at an early age. So the incidence is very difficult to ascertain, and it depends on who is um, examining the hip and how he is examining the hip, whether clinically or radiologically, and which part of the country he lives. Even though a fair degree of approximation dislocation occurs at 1.4 per thousand live births, and ultrasonography picks it up much more often. So it is more in Asians. It's
Hello.
more in it's more in Americans and less in Asians and Africans. So etiology, very important point to remember, is that the normal hip development is the outcome of reciprocal interactions between the femoral head and the acetabulum continuously till the adulthood. And any abnormality which precludes this kind of concentric reciprocal relationship is liable to get the hip dysplastic. Such etiologies might be ligamentous laxity, breech position in utero, or the postmental positioning such as swaddling position in hip and knees in extension, or it might be due to primary acetabular dysplasia. Whatever be it, these are the etiological factors. Now, risk factors, one picture says it all. It's the firstborn girl child with a positive family history and history of breech presentation during the pregnancy. The normal neonatal hip anatomy shows the cartilaginous acetabulum pristine, and the labrum is in continuous conformity with the acetabular curvature, and the capsule is reasonably tight. Once the hip goes on getting more and more subluxatable and dislocatable, the hip capsule gets stretched out, the ligamentum teres goes on getting elongated, and the labrum goes on getting everted. So much so that in a completely dislocated hip, the ligamentum teres is hypertrophic and quite elongated. The capsule is very, very much stretched out with an R-gas constriction secondary to the external pressure exerted by the iliopsoas. And now that the acetabulum is not covered by the femoral head, it is occupied by the fibrofatty tissue called the pulvinar. In the clinical examination in an infant, there would be an asymmetrical and increased thigh folds, and posteriorly there will be an asymmetry of the gluteal folds. In bilateral cases, there would be an widening of the perineum. There would be decreased abduction, and upon flexing the hips and the knees, the involved knee will be at a lower level, and that is called the Galeazzi sign. Ortolani's test and the Barlow's test would be positive, but it is important to remember that they might not be positive in an overtly dislocated irreducible hip. Klissick test for bilateral dislocation, which means one finger at the greater trochanter and another one at the over the anterior superior iliac spine, and the line joining them would pass below the level of the umbilicus, is another clinical sign for developmental dysplasia of the hip. And we should also look for associated conditions, which are torticollis and metatarsus adductus, which are very fairly common in these cases of developmental dysplasia of hip. In a clinical examination, in a walking child, there would be Trendelenburg gait and sign, which has already been described in POSI Gurukul 1. In bilateral cases, this would be called an waddling gait. And there would be still limitation of abduction, increased lumbar lordosis. There would be a limp with a component of short limb gait, and or else there can be a compensatory equinus in order to compensate for the LLD. The telescopic test would be positive on clinical examination. Now, a simple tip for examining a child with developmental dysplasia of hip performing auto-learning and Barlow's test is that we cannot perform the test in a crying child. So the child must be calm and contented, and he or she should be placed on a firm couch so that the hips don't sink when we do the maneuvers. We should our center of the palm should rest against the knee, and the thumb and the lateral forefingers on the proximal, medial, and lateral parts of the thigh, respectively. Both hips are held simultaneously, but one hip after another is tested. A gentle adduction maneuver, along with a gentle push towards posterior, would dislocate a dislocatable hip, and that is the Barlow's sign. And the opposite maneuver, that is abduction, along with just a anterior thrust, would relocate a dislocated hip, and that is the ortholannis sign. After the clinical examination, the neonatal hip ultrasound is the easiest and the most widely used modality to diagnose or confirm a suspected DTH in a neonate. And it can also be done repeatedly without any radiation or anesthetic hazards in order to monitor the progress. Now, two methods are very favorite of the question examiners. One is the graph method, and another one that the examiners are very fond of asking is the Harkey method, because that is the dynamic method akin to Ortolani and Barlow's clinical test. By far, the most widely accepted is the graph method, which is based on the static calculations. It is very easy to perceive if we consider that the person's coronal section with respect to the pelvis is what we see in the ultrasound pictures. Now, the outer border of the ilium becomes vertical in this position, and the angle subtended along the slope of the acetabulum becomes the alpha angle, and the line joining the tangent to the outer border of the femoral head becomes the beta angle. So it is very easy to understand that the graph classification, which progresses from class 1 to class 4, from mild to severe, is based on the fact that alpha angle goes on getting reduced and the beta angle goes on increasing as the grade of severity increases. In order to understand the X-ray of a neonate or a child, we must understand that much of the pelvic bone is unossified. In fact, the femoral head itself gets ossified only at about the age of 4 months. So much of the things that we see in the adult is not noticeable or not visible because of their cartilaginous nature. Even though many things are not perceivable, but many other things are. So two most important lines are Perkins lines, which also fortunately the perpendicular and easier thing to understand. A perpendicular line, which is the line drop from the lateral edge of the acetabulum, and the Hilgenreiner's line, which is again fortunately the horizontal line as well, which is the line joining the superior margins of two triradiate cartilages. Once we draw the line, many other things become evident. Once we subtend the angle of the acetabular slope, it becomes, from the Hilgenreiner's line, it becomes an acetabular index, and the ideal acetabular index is less than 25 degrees. Once we subtend an angle from the vertical line, that is a P line, into the center of the femoral head, if it has ossified, then it becomes a center edge angle of the Wilberg. Many other things are also noticeable, such as increased medial gap and hypoplasia of the ipsilateral iliac blade in the X-ray. Radiographic classification revolves around the position of the center of the femoral capital epiphysis with respect to the acetabulum if the femoral capital epiphysis has already ossified, and successive proximal and lateral migration of the femoral head means more severe grade, and that is called Tony's classification. If the femoral capital epiphysis has not ossified yet in very young children, the classification can be based on the position of the midpoint of the proximal femoral epiphysis with respect to the acetabulum, and its proximal migration in a similar way can denote more severe varieties. The treatment In the age group of less than 6 months, the gold standard method is application of Pavlik harness. It is used full time, and it guides about how to apply the Pavlik harness. It is noteworthy to remember that the child is not absolutely immobile. Some movement actually happen, and these movements are important to guide the femoral head into the reduction and prevent avascular necrosis. Also, it is a posterior straps which avoid adduction and dislocation of the hip. Now, a child with a Pavlik harness full-time application has to undergo weekly clinical examination as well as ultrasound for the next 3 to 4 weeks. And ultrasound examination, we expect, would show better parameters with successive weeks. And if that doesn't happen, then the Pavlik harness has to be discontinued and some other modality has to be contemplated. And if it shows a good reduction, then we need after 4 to 6 weeks of full-time bracing, and we need over next 6 to 12 weeks. We also for signs of femoral nerve deficit on every visit. Contraindications is irreducible hips that are not dislocated, that are not reduced, or they are not kept reduced during the course. Signs of femoral nerve palsy and too tight or too lax hips. In the age group of 6 months to 2 years, the gold standard is hip spica application after close reduction and better supplemented with an arthrogram intraoperatively. So in close reduction, the patient has to be under general anesthesia and the hip is flexed beyond 90 degrees, and sometimes adductor tenotomy might be performed. I am sharing the screen of that. Just a minute. I'll just stop sharing screen and then do a new share. Yes. So this is the child in whom we are going to. Do you see the telescopic test that is going to be performed? And now that is a method of close reduction, a gentle traction, flexion of the hip, one thumb over the greater trochanter and reduction. And then we have to check the stability of the hip. If we find that the adductor tendon is tight, then we do the adductor tenotomy percutaneously near the site of origin where it is tendinous. And we perform it with the blade facing away from the neurovascular bundles, that is the blade facing medially. After adductor tenotomy, the range of motion of the hip is increased, especially the abduction. I'm going to stop the screen sharing. And we're going to share another video which is regarding the hip spica application. Now, once the hip has been reduced, the child is placed on the spica table and hip spica is applied with sufficient precautions. Now, if the hip is stable only through a narrow range of motion, then it has a narrow safe range, and some other modalities should be contemplated either during that session itself or later on in another operative time. And if the hip is stable through a wide range of movements, then we can expect that the hip is going to stay that way inside the spica also. So back to the presentation. An intraoperative arthrogram is very important because it lets us see the inside of the hip joint in greater details. Typically, a subadductor approach is employed, and it beautifully shows all the things that are present in the pathoanatomy. So this is the labrum, which corresponds to the picture. This is the iliopsoas tendon, which is hampering the reduction. This is the constricted capsule, and it indeed shows the hourglass constriction. This is the ligamentum teres that goes all the way from the femoral head into the acetabulum, and this is the empty pulvinar where the dye has not been able to go into because of the fibrofatty tissues. And a medial dye pool of more than 6 millimeters usually is considered pathological. So we have already gone through it. Spica cast positioning, 90 to 120 degrees of flexion, 30 to 40 degrees of abduction, 10 to 15 degrees of internal rotation, and no more. We tend to avoid frog position, as we have already answered during the question and answer round, and we adopt a more human position because human position is for humans. If we are in doubt about the position of the hip in the spica cast, it is a good way, good thing to go for a CT scan even before the the medial approach or the anterior approach. In medial approach is particularly in less than 18 months of age. The child older than 2 years requires open reduction, and open reduction alone might suffice, or open reduction with femoral osteotomy, which gives us a chance to do femoral shortening, varicization, and derotation, can also be employed. The open reduction with an acetabular procedure can also be employed, where we perform various types of osteotomy, or all these procedures can be combined into one. Now, the medial approach, which is a fairly straightforward, simple approach, and which addresses the issue directly by going through the medial side of the hip joint, and the child is positioned supine, a transverse skin incision, and the facial incision is longitudinal, and we try to reach the lesser trochanter directly by finger palpation, and then retract it, find the iliopsoas tendon, divide it, and then do the capsulotomy till the transverse acetabular ligament, reduce the hip, take out the pulvinar and reduce the hip, and check it under fluoroscopy or X-ray, and apply hip spica for the next 12 weeks. The advantage is direct approach to the obstacles to the reduction, and it can be performed in bilateral surgery. The drawback is and controversial, more avascular necrosis risk, and useful till only 18 months of age. Other procedures such as capsulorrhaphy for loose capsules, then acetabular procedure, and femoral osteotomies cannot be performed through the same incision. Now, the anterior lateral approach, which is also called the Somerville approach or the anterior approach, is the most widely used and accepted approach to the hip with a DDH. Now, we would like to stop screen sharing again, and I'd share a short video on that. It is already running. Okay, so anterior open reduction is useful in those cases where the constriction is so severe that the capsule assumes an hourglass position. Now the child is placed supine and the limb is draped free. An adductor tenotomy has been performed already to increase the range of motion. And now let us visualize how the hips looks like in supine position. So the plane of the dissection is between the sartorius and the tensor fasciolata, and immediately after the skin incision, the lateral femoral cutaneous nerve comes into the view, and which has to be protected. Now, next we would find, going through the plane, we would find straight and reflected heads of the rectus femoris, and which have to be divided as well in order to gain the exposure. After this, we find the iliopsoas tendon, which is in close proximity with the neurovascular bundle, and that has to be taken care of while dividing it. Once we have already divided it, the hip capsule along with the dislocated hip comes into the view. Getting back to the surgery, incision has already been applied. That is the femoral cutaneous nerve that we can see it has been protected, and this is the plane of dissection between the tensor fasciolata and the sartorius. Retracted. The iliac attachment of the tensor fasciolata is divided to gain deeper into the incision. Now this is the rectus femoris, the straight head and the reflected head. The reflected head is confluent with the hip capsule, and the straight head attaches onto the anterior inferior iliac spine. After isolating and separating out from the nearby tissues, it has been divided after tagging it with sutures for future reattachment. Okay, so here we are gaining more and more access into the deeper layers of the hip. This is the iliopsoas, which remains in close proximity with the femoral nerve. It has to be isolated in similar fashion and divided after testing. The exposure of the iliopsoas is easier when the hip is flexed, and also rotations are performed in order to ascertain that the muscle is the iliopsoas indeed. Now we are on to the hip capsule, and the hip capsulotomy has been performed. It comes in a standard T fashion, perilabral horizontal line, and the vertical line of the T is along the neck of the femur. The capsule is given some stay sutures, and the excessive capsule is being excised so as to gain greater visibility and also to do away with the redundant capsule. Now the shiny part that we see is obviously the hip, and now we are checking the stability of the hip, which won't be much because the pulvinar in the acetabulum has not been excised yet. So this is the redundant capsule, which when incised gives us greater visibility and greater exposure. This is the ligamentum teres, which has been excised. And now this is how it looks like. This is the pulvinar. And when this is removed, the true acetabulum is revealed. Now we perform the test of stability. If it is stable, we do the capsulorrhaphy and check it under IITV, of course. Do the capsulorrhaphy. Place the rectus back into the position, and then attach the tensor fasciolata again. If we need to give a lot of pressure in order to reduce the hip, then we understand that this tremendous amount of pressure is going to cause avascular necrosis of the femoral head and damage the cartilage as well. So then, in order to prevent the excessive pressure, we perform femoral shortening osteotomy. Through the lateral approach, we do an osteotomy at or below the level of the lesser trochanter, and then reduce the hip without tension. The amount of overlap that remains there needs to be excised, and that is called a femoral shortening. This also gives us the chance to perform derotation and varicization if required, and we fix it with a plate. I'm going to stop sharing the screen and go back to the slides. One method of capsulorrhaphy without excising much of the capsule is pant over vest technique, where we tuck it like a shirt in the medial part of the capsule, and then we can close it like zippers of the pant. Then it becomes pant over vest capsulorrhaphy. So we have already seen that femoral shortening and derotation osteotomy combined with open reduction After doing that, we place the patient in hip spica for about 6 to 12 weeks, and depending on the stability, and then it is supplemented by spica removal and a hip abduction brace for next 3 to 6 months. If after addressing the femoral component of the dysplastic hip, if the acetabulum is not well formed, then we perform pelvic osteotomies. The details of the pelvic osteotomy require another POSI PG Gurukul in itself, but still we would like to catch the important points. So the complete pelvic osteotomy changes the orientation of the acetabulum, and it changes the inclination. The incomplete pelvic osteotomies rather change the slope and shape of the acetabulum, and the salvage procedures increase the volume of the hip osteotomies. Let us find those out. One of the commonest pelvic osteotomies is the Salter's single innominate osteotomy, which is capable of providing at least 15 degrees of lateral coverage and 25 degrees of anterior coverage. Over here, a through cut is made through the ilium, and wedge is opened and kept in place with the help of graft and Steinman pins. This is called a Salter innominate osteotomy. We can also cut 2 pelvic bones, or we can also cut 3 pelvic bones to completely detach the acetabulum from the parent innominate bones and reorient it in a better position. We can also do a periacetabular osteotomy of gans so as to take out a smaller chunk of bone around the acetabulum and reorient it back in place in order to gain greater pelvic stability. In incomplete osteotomies, we try to change the slope of the acetabulum and shape of the acetabulum depending on the plasticity of the triradiate cartilage. So we perform, for example, a Pemberton osteotomy just immediately over the supraacetabular region. That's an incomplete osteotomy, and place it with keep it in place with grafts, and it gives us anterolateral coverage, but it can be performed only till the time the triradiate cartilage is open. Now, sometimes the hip is so dysplastic and the child is so old that we have to perform some salvage surgeries, in which we just try to increase the volume in order to keep the hip in place. So then we perform the Chiari osteotomy, and we perform an innominate osteotomy like this, and place the distal fragment pushed medially rather, in order to decrease the joint reactive forces, and also to provide a pseudo coverage by the proximal aspect of the fragment after the osteotomy, so that it provides a sort of roof. So the complications of surgery include redislocation, resurgeries, infections, hip stiffness. But the most important thing that we should be aware of as a complication of surgery of developmental dysplasia of the hip is a avascular necrosis, because in natural history of the DDH, there is no avascular necrosis. So whatever has happened, it is due to iatrogenic causes. Extreme abduction and internal rotations are sometimes attributed to this. Sometimes the contracture of the muscles around the ear to ossify, no growth within 1 hour of reduction, or gradual and progressive deformity. So this class avian has also been classified and mentioned in the Tachyons, and it is based on the type of avascular necrosis that happens depending on the site of the avascular necrosis. In type 1, there is just irregular ossification of the femoral head, and it doesn't require any active intervention. In type 2, there is a lateral head and metaphysis is involved, and it causes progressive caput valgum or increases the neck shaft angle or head neck angle. In type 3, the whole head and the metaphysis is involved, and there is relative trochanteric overgrowth. And in type 4, there is medial head and the metaphysis is involved, and it might cause varus deformity. So depending on the type of deformity that has occurred, we can treat that. If we are already anticipating and trochanteric overgrowth even before it occurs, then we can arrest the growth of the greater trochanter by doing an epiphysiodesis. We cut a large chunk of bone across the physis and place it upside down again back into the place, which causes a physeal scar. Or we can use screws, or we can use growth modulation aid plates in order to arrest the growth of the physis. When the trochanteric overgrowth has already occurred, if the neck shaft angle is preserved, we just need to distalize the trochanter to get back the original head and trochanteric relationship. If the neck is short, then we can make the trochanter and the proximal shaft a part of the neck, and we can elongate it and then distalize the trochanter in order to gain a normal neck shaft and trochanteric relationship. Just a word about the teratologic dislocation. Whenever we come across a teratologic hip dislocation, we must understand that it occurs early in the embryonic life, and it is a part of the larger syndrome complex. So these are characterized by typical phases, and multiple joint involvements would be there, upper limbs, then knees, ankle, foot deformities, and multiple system involvements might also be there, and there might be a positive family history. So in these cases, if we encounter them during our practical life or in the exams, we must understand that these hips are resistant to conservative treatment, and we should have a low threshold for open reduction. And these have multiple comorbidities. They might need multiple surgeries, and the outcome is not as good as developmental dysplasia of hip without any syndromes. So take home point, they say that it is difficult to diagnose a DDH, but it is easy to treat. But now that we have come to learn so many things about DDH, now it should be easy to diagnose and easy to treat in the young. And in older children, it is easy to diagnose, but it is very, very difficult to give a very good result as the age of the child progresses. And in the online, you can take help of multiple websites: International Hip Dysplasia Institute, Global Health, and Pediatric Orthopedic Society of North America for research papers, videos, and other resources. Thank you. I'll stop sharing the screen.
Thank you, Sukayan. So you covered comprehensively about developmental dysplasia of hip in all aspects, and you actually did good animations and videos, which will be very helpful for the residents, I think. So it was very good. Thank you.
Thank you, sir.
So now call upon Dr. Thomas, and I think Sandeep is on and off. Hitesh. To start the discussion with the residents. Dr. Thomas.
Dr. Thomas, would you unmute your microphone?
Hitesh cannot unmute. I cannot unmute. I think I may be able to unmute.
Wait, I'll enable. Okay.
Yeah, and I think Ashok, you can enable everybody to unmute, because some of the residents.
Yeah, fine. I just got to unmute. That is a very nice presentation, Sukayan. Very nice illustrations and pictures on videos on dislocation on the anterolateral approach. I just want to add a few points for the students, who are very new into the field. I think you have to, for the exam point of view, very rarely do they keep a DDH. So it's mostly for theory. You get a lot of questions on Ortolani, Barlow, on ultrasound, on graph, and in the operative thing, you may need to describe the anterolateral method at the most. I don't think they will go into osteotomies. But if you get a case in the practical exam, it may be a case of post-septic dislocation or a PFFD or a late older child with dislocation, which is it can be kept as a short case. So the history for people who are just starting the MS is very important. I think he didn't dwell a little bit on history. So the history of whether the child was first born, whether it was a breech presentation, what was the birth weight, there's a family history. All these are very important, critical when you're dealing with the DDH. Also in general examination, was there ligamentous laxity? Was there torticollis? Did you examine the neck? Was there metatarsus adductus? Is there a foot deformity? Was the knee? How is the knee? Then examining abduction or movement of the hip. Very important. If you don't pick up that unequal abduction in an older child more than 3 months, up to 3 months, you can do Ortolani and Barlow. After 3 months, it loses its sensitivity. You have to go by unequal abduction. Even the creases don't have very good sensitivity. So those small points are very important. Even when you start your practice, these very small, very important to get a good history. Examine the child from head to toe. And the other points were about, as I said, the Gagliardi, doing a good Gagliardi test by keeping both legs, bringing it to the butt, almost touching the buttocks, and reading the knee levels. Very important, doing a good Gagliardi. And in a bilateral dislocation, even experienced people can miss a bilateral dislocation because the Gagliardi will be negative, you won't get the creases. So, and abduction will be limited equally. So it's sometimes very difficult to pick up bilateral dislocations. So if you see a child with hyperlordosis or a waddling gait, immediately your antenna should pick up that this could be a bilateral. Similarly, we have a dimple on the thigh or some shortening of the leg. You must think of postseptic and the PFFD. Sometimes they can keep in your exam. He mentioned about acetabular index, so it's not always static at 25 degrees. At birth, it can be 27.5, and with age, it can decrease. So at the age of 2 years, it should come below 20 years. So it's not always static, like Sukayan mentioned, at 25 degrees. Also, the indications of Pavlik, when do you put a Pavlik? So some people put it when there's less than 50% of your alpha angle or less than 40% coverage. Some people do it for a graph grade 3. And you can only do a Pavlik for 3 weeks. And every week you have to actually monitor with ultrasound. And after 3 weeks, you have to discard the Pavlik if the hip doesn't get concentrically reduced. That's called trial of Pavlik. That can be asked. Then you do a Pavlik between 6 weeks of age to up to 5 to 6 months of age. After that, there's no role for Pavlik. You normally go take the child into theater, under anesthesia, do a closed or open reduction. He mentioned about closed reduction, but again, the importance of the whether it's concentrically reduced, the stability of the reduction, whether it's wide, the legs are wide in abduction, which can preclude an avian position, which will then you may have to abandon closed reduction and then proceed to open reduction. Although books say you should do only closed reduction at around up to 18 months, practically there are people who do up to 2.5 years also. But for the most textbooks tell you after 18 months, if closed doesn't work, you may have to go into open reduction. That's fine. Then after you do an open or closed, I think it's important that you do a CT limited cut or MR. There's no ifs and buts about that. You have to do. It's a 3D visualization. Just doing an X-ray is not enough. You have to do a MRI or a 3D, or a limited cut CT to visualize a 3D reduction of your. There are people abroad in the West who actually do an intra-op ultrasound or the II, which has a 3D thing to show that it's concentrically reduced. So just an X-ray will not suffice. Then when do you do an open reduction? When you he mentioned about all the methods of open. So for a MS student, they may not ask you about medial open. Many centers don't do medial open because of the high rates of avascular necrosis. But you should know the interval of each of these, like he mentioned, the interval of approach, because in the operative technique, they can always ask you the method of open reduction. Then the two positions that you should know is in close reduction, you do the human position, which is about 90 to 100 degrees. Venkata showed a thing about Lawrence position, that's extreme abduction, but the position which is after close reduction is a human position, 90 to 100 degrees of flexion and around 45 to 60 degrees of abduction. Whereas the position after you do an open reduction is called the Salter position, which is less than 60 degrees of abduction and only around 45 to 60 degrees of flexion. And the spica application is very important. They can ask you the complications of spica, complications of Pelvic. Those are all very common questions. Okay, that's about what I had to just add on to that presentation. I'll be happy to take questions. I don't know if Sandeep is around.
No, Sandeep is
He
not
has
there.
something to
Hitesh
add.
is.
Yeah, good
Yeah,
evening.
Hitesh wants to add something. He's welcome.
Good evening, Thomas. Good evening,
Hi, hi.
Dhiren bhai, good evening. Good to see the Sukayan. You have included almost everything. Can you hear me?
Yes.
Yeah,
Yeah,
we can
yeah,
hear you,
loud
Hitesh.
and
Go
clear.
ahead.
Yeah. So now the Thomas has mentioned the most of the things, because the most of the postgraduate will get the older child with DDH, or very common scenario in a Indian scenario is a post-septic dislocation or Tom Smith arthritis. The commonest differential diagnosis, they will ask that, what do you think? So why it's a DDH or a post-septic? The answer would be there. If there any history of neonatal infection or neonatal ICU admission, you can think about the post-septic dislocation or Tom Smith arthritis. The point between in a clinical examination, when we see the range of motion of the Tom Smith arthritis, all the movement would be exaggerated, while the DDH, the abduction would be restricted. Other than that, the most of the clinical features would be the same, and the X-ray would be the diagnostic to differentiate between the post-septic dislocation and the developmental dysplasia of hip joint. Whenever we'll see deformation of the femoral head or sclerosis or irregular femoral head or neck, we can see that will be post-septic dislocation. The prognosis would be very, very different. Thomas has already included the most of the things. So when can we do the close reduction? When can we do open reduction? Another important point for the DDH in general examination, the examiner will ask the ligamentous leg. So they may ask sometimes about the Britton score or any other score for ligamentous laxity. The child with DDH would be always associated with ligamentous laxity. And what he mentioned, the close reduction can be possible in 2 years or 2.5 years. Those children will have ligamentous laxity. So it is possible to get the close reduction in the also. But the message is there, whenever we feel it tight or a forceful close reduction, only extreme internal rotation or extreme abduction, it is stable, then we should not hesitate to do the open reduction. So indication for open reduction, that is very commonly asked the question, if the child would be around 2 years and it will be kept in exam, when will you do the open reduction? If it is not reduced, if it is not stable, or it is stable only in abduction and internal rotation. Another important point Thomas mentioned is bilateral dislocation, and the expert also missed that is the important, because very common scenario, the child would be very cooperative, would be kept in exam is 5 years or 6 years, and very common the child would be having hyperlord, and that is the point where we can pick up with some of the amount of the flexion deformity. And many of the old examiner will like to have the line where we can say whether it's unilateral or bilateral with trochanter, and many times it will be asked what are the examination points. So you can say this is a case of DDH. You say there is a vascular sign of Nareth would be positive, telescopic is positive, Trenberg is positive, then they can say it's a case of DDH. Another important points, when you will not do the treatment of DDH, that is also commonly asked the question to the postgraduate. it is actually a very controversial question. It is safe to answer when we are not going to get the congruent hip after some times, because the practicing pediatric orthopedic surgeon, which is having reasonably good experience, they can extend the higher limit of doing open reduction 8 or 10 years. But for the in exam, we can say if we are not going to get the congruent hip, which is going to be cause of a non-painful, then we can go the open reduction. So age is not the indication, but by and large, it is well accepted in international standard. We can say if it is bilateral more than 5 years, it's a think about pinch of salt, and unilateral maybe 7 to 8 years, because that is one of the controversial question.
Yeah.
All right.
Those are very important points. Just two more things. One is about Clisic's test in bilateral, and how
We
to
can
do the
ask one of the
Clisic's test
residents
with
to
your
tell what is
3 fingers,
Clisic's
and
test. Thomas?
it should intersect.
Yeah, we can ask one of the residents to tell what is Clisic's test.
Sure.
Vigneshwaran, are you there?
Yes, sir.
Yeah, can you tell what is Clisic's test and how to do it?
So you have to place the finger over the GT and over the ASS, and if you extend up to the umbilicus, if it goes through the umbilicus, it is not dislocated. If the line goes below the umbilicus, it is that side of the hip is dislocated.
Yeah. So at or above is okay, but intersects below, it's a positive Clesic. So in a bilateral dislocated hip, your Clisic's test, apart from your hyperlordosis and your waddling gait or bilateral Trendelenburg, very important. That is one point. And when does the femoral head ossify?
By 3 to 6 months, it will be ossified. So after 3 months, we can start doing the X-ray to observe what is the stage of it.
Of doing at 4 months, if the head is not ossified, can you say it's dislocated? Is there a classification?
Sir, through IHT classification through the Center of Proximal Femoral Metaphysics.
Now you should be aware of that International Hip Dysplasia. So the 2 lines and the intersector and the 4 grades you probably should know. That is one thing. And what Hitesh said about the age of open reduction, is very important. Unilateral in certain textbooks say up to 8, and in bilateral above 6 or 7 you don't do, because if you put it in after so much time, the articular cartilage is already denuded, and you'll actually cause arthritis. So it's better left outside so that the child can walk, become a young adult, and you do a THR around 25 or 30. That's better than intervening and causing pain and arthritis faster. Okay.
Yes.
So generally, the rule of thumb: unilateral up to 8 or 9, bilateral above 7. Most examiners will say you should not reduce.
Okay, is there anything else to add upon? Dhanil?
Yes, sir.
How will you do a telescopy test?
We will hold the GT. First, we will hold the. We will stabilize the pelvis by holding on the superior pelvic spine, and we'll hold the GT, and we'll pull. We'll move to and fro. Pistoning of the. We will do.
No. You will not hold the greater trochanter, right? Where will you hold the limb?
Hold the thing.
So usually in exams they keep older kids with DDH, unilateral or bilateral DDH, and most of the children who are kept for exams will have positive telescopy tests. So you should know how to demonstrate a telescopy test in the exam. So that is one of the tests which they would ask you to demonstrate in the exam.
Actually, we will hold the, if it be bigger, we will hold in the axilla and the knee, and we'll adduct around 10 degree, and we will hold the arm palm around at the GT, and we'll stabilize the pelvis with the opposite end, and we'll do the pistoning movement.
Okay. You should have a very clear idea, right? So with your hand, with your great thumb should be on the anterior superior iliac spine, stabilizing the pelvis. The middle finger should be on the greater trochanter. The other hand, you should hold the distal end of the thigh, and then you piston in and out and see whether it is moving. So that is how you, with a little bit of adduction, actually, flexion and adduction of the limb is preferable to get the telescopy effect. So that is one of the clinical signs which you will might have to demonstrate when you get a case. And any other tests which you routinely ask students to demonstrate in a case of DDH, Thomas? Of course, they don't keep very young children for you to demonstrate Barlow and Ortolani. So Trendelenburg is another sign which they would ask you to demonstrate the Trendelenburg test. So any hip case they will ask. So they should be very well versed to know to how to do a Trendelenburg test. So these are the two tests which they can ask you to demonstrate as such. So any of the students, yes sir.
Topic from the theory point of view, because even now I think in the MD pediatric exam, the essay was DDH. If I'm not this for MD pediatrics this time, the essay was on DDH. Can you believe it?
Okay.
Not orthopedic.
Yes sir. Yeah. So DDH is one thing which they will no, it can come in various places.
Can come from your obstacles of reduction, Ortolani, Barlow, a long question on DDH. What Sukayan said about all the osteotomies, any of them, Salters, anything can come. And AVM.
And even in the afternoon Viva, they will ask about the approaches, and osteology, they will ask about pelvic osteotomy. So if this is one topic which is it can help you in the exam in various places. If you're well versed with this topic, you'll be able to definitely answer in many places.
But as soon as they pass and they get into practice is when all these nuances and small practical points become very, very important.
Yeah.
And Sukalan showed a nice video of spica casting and open reduction. So if people have seen it and then you read it, you will retain it better.
Yeah. So there is one question by Abhishek Parashar. So is asked any role for PSO for older children, pelvic support osteotomy, in a neglected DDH? That's what he means, I guess. Abhishek, is that what you want to ask? Yeah.
Yes, sir.
So it's a little controversial. So if it's a little controversial, but you normally do operations for the patient. So if there's a lot of limb lurch, and if it's a girl, to bide some time for your THR, because nowadays with a lot of advances in THR, converting a PSO to THR is no big deal. So there are people who do conversion very easily. So the old thinking of conversion of PSO to THR being very difficult is one of the precluding factors doesn't hold anymore. So if it's a girl and if she's worried about her image or walking, too much of waddling and the parents feel or she feels this thing, we offer it to them.
What is the age?
You can do multiple times, meaning you can do below 10 years.
Okay.
And then it'll remodel. You may have to repeat it again. We've actually done 2 or 3 times on one child itself as she grows.
Okay.
Yeah, PSO.
So there is. Go ahead,
Venkatesh. PSO in DDH is little controversial. PSO is very commonly indicated in case of the post-septic or Tom Smith. But the DDH is, as per se, it is controversial because the child will not have the pain in 6 months. And second, what you said rightly is that what is the ideal age for doing a PSO? Because if the postgraduate must understand if the PSO is done, PSO is a pelvic support osteotomy. That is, in term of the exam, it will be asked by the examiner, what are the osteotomy, Lawrence and Sons, with or without excision? Basically, it's a pelvic support osteotomy. But if we do in very early, if the child is very young, less than 10 years, then it will remodel quickly. So the ideal age for the osteotomy is actually at the growth spurt, just before the skeletal maturity, it would be ideally. But then what to do between that time, that is also one of the issue. So you can say you need to do with the both, deal with the unstable hip as well as the shortening. So it has been done for the unilateral cases where it has become painful. Then you can think about the PSO. And most of the cases it will be associated with distal femur lengthening osteotomy.
Okay. So Yeah, I think that is very clear. And one of Dr. Vigneshwaran has asked a 2-month-old child with DDH, which is not reducible in Pavlik trial for 6 weeks. So when can we do close reduction? Sukayan, do you want to answer that?
Yes. So
2-month-old child failed Pavlik. So when to do open reduction? It's a very practical question.
And yes. Yes.
Sukayan, your voice is breaking.
Yes.
Yeah.
Very practical. So the hello, can you hear me?
Yeah, go ahead. Yeah. Go
hello.
ahead.
Yes. So the next thing after a failed Pavlik harness is something which needs anesthesia. So we have to see whether the child is, capable enough and our facilities are good enough to keep the child under anesthesia. And then we go ahead. If the child is all right, if we have got an expert anesthesiologist to give anesthesia to a young infant, then we go ahead and do a close reduction and hip spica, okay, along with an arthrogram. If not, if the child is not big enough, if the operative interventions are to be delayed, then we can easily wait till 6 months.
Right.
And then we can do the close reduction and hip spica along with an arthrogram. At the same,
the answer you should give to the examiner is that it's not 6 weeks. So after 3 weeks of failed Pavlik, you should abandon Pavlik harness. It's not 6 weeks. 3 weeks of Pavlik doesn't work, abandon. Okay.
Yes, sir.
And then because of the, like Sukayan mentioned, the risks of anesthesia are higher when it's 3-month-old, 2-month-old. You would rather wait for 6 months of age so that the risks of anesthesia are reduced. So I would prefer that the answer from a PG comes that I will wait till 6 months of age when the risks of anesthesia are minimized, and then I will take up the child for close reduction into theater under anesthesia. That is the answer we expect from students.
Sir, meanwhile, we have to immobilize in some other
No,
form,
you don't
or we
have to
can
immobilize.
leave the
You can
hip
let the child just be,
free.
don't restrict the child. Yeah.
Yes.
Another
will cause AVN if we restrict the child.
Sorry. Yeah. Another comment, I will say that whenever it is irreducible in a child, it's very rarely will have so many irreducible. So if it is irreducible in a very young child, think about teratologic dislocation. Because if it is teratologic dislocation, that is the Pavlik harness is not indicated. So generally what is there, if it is irreducible hip, what Thomas is telling, it's not a 6 weeks. He's rightly said that actually, ideally speaking, 1 week, 2 week, maximally you can stretch up to the 3 weeks, because more than that, it will lead to the more harm that is called as Pavlik disease rather than doing about helpful. So if it is not getting reduced, okay, beware that it should not immobilize immediately. So you can leave it for some time, because the harness can produce the more issue. Other than doing that, about the no immobilization period would be good.
Yes, sir.
And the next question was, how long can you wait for doing an acetabular procedure if the acetabular dysplasia is not improving in an 18-month-old child? So that is again a controversial question. I think Hitesh, can you answer that?
Ideally, there is no ideal answer for that, but it is well accepted that hip is inside and well concentric reduction with well centered hip. If you wait up to 2 years following, that is good. But that also depends on the age. If it is 18 months old child is got the reduction quite well, you can wait up to the 2 years. But I always think that, and progressively you can do and follow up that whether the senton is getting okay, acetabulum is not getting corrected, and hip is not getting decentralized. If angle is getting changed, then yes, you can do it intervention. But the ideal answer is there, you need to do follow up and 2 years.
Right. Sukayan, do you have any questions on your WhatsApp?
I'll just add on to that, Venkat.
Yes, sir, go ahead.
Yeah, there are two schools of thought on that. So the earlier school was you reduce
Hello. Dr. Thomas.
He's come back. He's mute.
Yeah, can you
No,
hear
there
me?
was, yes.
Yeah, so there are two schools of thought on that. One is you reduce the hip, watch for acetabular development every 6 months for secondary ossification centers to develop. And if your acetabular index doesn't improve, you go ahead and do a secondary pelvic osteotomy. The other school of thought is that you do the open reduction and the pelvic osteotomy at the same sitting.
All right. So that's what it's a little controversial. Okay, so we don't have any questions on the WhatsApp forum. And any of the students, if you have any questions, you can ask Dr. Thomas or Hitesh. They're here to answer all your clear or your doubts. This is the time to ask questions and clarify your doubts about DDH. Now, it's a huge topic. We are trying to cover whatever is being commonly asked in the exams. And if there are no questions, I think we can end today's session. Thank you, Sukayan, for an excellent lecture, and thank you, Dr. Thomas and Hitesh, for enlightening our students. Thank you all the delegates for joining us today. And last but not the least, thank you, OrthoTV and Ashok, for tirelessly supporting us for this endeavors. Thank you, one and all. Good night.
Thanks. Thanks, Venkatas.
Thank you, sir.
Thank you.
Thanks.
Bye.
Bye. Thomas, bye. Thomas, good night. Neeraj, bye. Sukayan, okay. See you. Bye.
Okay. Good night, sir. Good night. Thank you so much. Thanks.
No, we'll eat, huh?